Okay. A 35-year-old woman with 3 pluses of protein in urine, urea 24, creatinine 268 micromole per liter, not a non-diabetic or hypertensive, has a positive history of NSAID use for recurrent joint pain for 4 months, has preterm edema. She has normal renal size on ultrasound scan. Mention 3 differential diagnoses. What is the most important investigation? Report of a renal biopsy was given as a histologic picture of a light microscopy with tubular interstitial sclerosis. Scarring, atrophy, and marked cystic dilation of the tubules was shown to you. What is your final diagnosis? Which 4 investigations will you do? How will you manage her? What is the latest drug combination for heart? So, question A. My differentials, the first differentials I have is tubular interstitial nephritis. Why? Because there is a history of NSAID use for 4 months as a result of recurrent joint pains. And also the history of proteinuria with elevated urea and creatinine. Yes, because NSAID is a cause of tubular interstitial nephritis. Renal ultrasound scan finding may be normal as in this case. And my second differential is nephrotic syndrome, which is secondary to NSAID use. NSAID has been implicated as a cause of nephrotic syndrome. And we have other things like presence of proteinuria, which is a nephrotic range. And patients also present with edema and normal size kidney, which is in keeping with nephrotic syndrome. So my third differential is lupus nephritis. Yes, there is history of NSAID use as a result of recurrent joint pains. Looking at her age, the joint pain she has could be as a result of lupus nephritis. Looking at the fact that she's young and then the joint pain is recurring, though there are other causes of joint pain. Yeah, but well, I think lupus nephritis is also a differential. So what is the most important investigation? For this patient, the most important investigation is percutaneous renal biopsy, which is the definitive diagnostic investigation for patient with tubular interstitial nephritis. So what is your final diagnosis? My final diagnosis is chronic tubular interstitial nephritis secondary to NSAID use. This is a result of a histologic picture of a light microscopy with tubular interstitial sclerosis, scarring, atrophy, and marked cystic dilation of the tubules, which was shown in the question. So in acute condition, patient will have infiltration by mononuclear cell. But as we can see, because of the presence of scarring, I thought it's likely to be a chronic tubular interstitial nephritis. And looking at the duration of NSAID use is for up to like 4 months. But then she also, most likely she has lupus nephritis, which is also a cause of tubular interstitial nephritis. But then the histologic finding is not in keeping with that. So most likely the NSAID got to her more than the lupus nephritis. So which 4 investigation will you do? I'll do a urinalysis for the patient where I will see proteinuria, albuminuria, beta-2 microglobulins may also be seen, hematuria, leukocyturia, eosinophilia may be seen, but then is absent if it is an NSAID-induced nephritis. So full blocker and ESR, she may have pneumocytic pneumochromic anemia with elevated ESR. EUCR will be in the range where she will have acidosis. Like in this case, patient has elevated urea and creatinine, so is in keeping. So I'll also do imaging for the patient, KUB X-ray ultrasound scan, and then non-contrast CT, where I will see the renal size. In this case, we are told that the renal size are normal, but then there could be increased echogenicity, calyceal dilation, and stones may be seen also, which are also other causes of obstructive nephropathy. But then for this patient, because of the scarring that is seen in histology finding, I still go with the chronic tubular interstitial nephritis rather than the acute, despite the fact that the kidney size is normal. So how will you manage the patient? Treatment is basically supportive, which is directed to cause. So the most important thing is to remove or to stop the offending agent, like in this case, which is the NSAID. And then it's important to look for what is giving her the pain that stimulated the use of NSAID. So like I said, because of the history of the recurrent joint pain, most likely she has lupus nephritis. But there are other things that we can consider. But considering her age is the topmost differential that I have. So most patients present with renal insufficiency, proteinuria, and or acid-base balance disorder, they may require consultation with a nephrologist. Like in this case, we have to manage her together with the nephrologist until the electrolyte, urea, and creatinine settles down. And this patient may require inpatient care, like I said, until stabilization or resolution of all these symptoms. And then for this patient, since I'm looking at chronic tubular interstitial nephritis, most likely it will progress to chronic kidney disease or end-stage renal disease, where she may develop anemia, and we should manage it as such using hematinics, erythropoietin, and we should be very careful with blood transfusion because she's a potential candidate for renal transplant. Vitamin D and calcium replacement is also important in this patient. And most importantly, we should avoid any other causes of nephrotoxin because it is going to continue the insult, which will worsen the condition of the patient. The patient will also benefit from diuretics, looking at the fact that she has pedal edema. And steroid can be used if after some days, if after conservative management, there is no improvement. MMF is also indicated. It has a role in this patient because of the chronicity of the condition. Chronic tubular interstitial nephritis may subsequently develop end-stage renal disease, and the patient may benefit from renal replacement therapy in the form of dialysis, and ultimately she may benefit from renal transplant, depending on the complications she has. So what is the latest drug combination for antiretroviral treatment? Is tenofovir, lamivudine, and dolutegravir. So briefly, I'll be talking to us about tubular interstitial nephritis using this outline. Tubular interstitial nephritis is a group of immune-mediated inflammatory disease that involve the interstitium and the tubules. Inflammation of the kidney consists of the collection of inflammatory cells, fluid, and extracellular matrix surrounding the interstitium, along with the infiltration of tubular cells by inflammatory cells that define both the tubules and interstitial pathology. It is one of the most significant causes of acute kidney injury that leads to renal failure. TN can be associated or can be classified into two. It could be acute and chronic, like I said, but then how to differentiate the two depends on the duration, because mostly their etiologies are similar, and most importantly is histology that will finally tell you that this patient has acute or chronic. Like in this index patient, the renal size are normal, which is not what we expect, because in chronic tubular interstitial nephritis, the renal size is mostly shrunken, but then never say never, I might say. So, but then the histology subsequently shows that there is scarring, atrophy, and dilation, which is in keeping with chronic tubular interstitial nephritis. Renal impairment with acute tubular interstitial nephritis is reversible, provided early and appropriate intervention are made. But chronic TIN may be irreversible in severe cases. Drug-induced nephritis is widely described and is a leading cause of TIN. So epidemiology, TIN constitutes about 10 to 15% of all kidney disease, both in the United States and worldwide. In such a region such as the Balkans, where we have the Yugoslavia and the rest of these places where endemic nephropathy is common, interstitial disease may be more prevalent. And in all, global incidence of TIN is about 1 to 3%, more common in the elderly, perhaps due to drug exposure and the presence of other triggers. So like I said, the etiology is similar for both acute and chronic, but the major difference is the duration of the exposure. So acute could be as a result of hypersensitive reaction to drugs, which include penicillin, sulfur, but most commonly is the NSAID. The NSAID is most commonly implicated, like in the case of the index patient. Immunologic diseases are also implicated, like lupus. So like I said, this patient has recurrent history of joint pain. Well, for now, for us to really know, we have to investigate along that line to do for the autoantibodies and the other things that we point to lupus. But then, like I said, it's also a differential. Acute transplant infection are also causes of acute tubular interstitial nephritis, where chronic, as you can see, is also the same drugs, but then the duration matters. And then obstructive uropathy, immunologic disease, like I said, ANCA-positive vasculitis, chronic transplant nephropathy, atherosclerosis, kidney disease, like the cholesterol microembolic diseases. We have metabolic conditions like hypercalcemia, cystinosis, hyperoxaluria. Neoplasias like multiple leukemia, multiple myeloma, leukemia, and myeloidosis are all implicated. And we have genetic disease like Alport syndrome, medullary cystic disease, and then miscellaneous like the Balkan endemic nephropathy. It's not common here, but mostly we see it in the Asian world. So the pathophysiology of TIN. Tubular interstitial nephritis involves the immune-mediated infiltration of the kidney interstitium by inflammatory cells. Lethal or sublethal injury to kidney cells leads to expression of new local antigen, inflammatory cell infiltration, and activation of pro-inflammatory and chemoattractant cytokines. In acute TIN, the tubular damage leads to renal tubular dysfunction with or without acute kidney injury. Regardless of the severity of the damage to the tubular epithelium, the renal dysfunction is generally reversible, possibly reflecting the regenerative capacity of the tubules with preserved basement membrane. Conversely, chronic TIN is characterized by interstitials carrying fibrosis, tubule atrophy, resulting in progressive chronic renal insufficiency, as we see in the index patient, for which the histology following biopsy is the final definitive diagnosis. The principal mechanism in the acute TIN is hypersensitivity reaction to drugs such as penicillin and NSAID, as in the case of the index patient. Another mechanism is acute cellular injury caused by infection, which could be viral, bacteria, or obstructive reflux. Transforming growth factor beta is a major precipitant of fibrogenesis in chronic tubular interstitial nephritis. It favors the accumulation of collagenous and non-collagenous membrane component by direct stimulation of projection and by inhibiting matrix degradation enzymes such as the collagenesis and metalloproteinases. Activation of nuclear transcription factor such as a nuclear factor kappa in injured kidney cell with consequent transcription and release of pro-inflammatory cytokines into the interstitium appears to be a major mechanism of chronic TIN, with inflammation accompanying proteinuria kidney disease. So how do the patient present? In acute TIN, the presentation may vary depending on the cause. Patient may have rash, fever, eosinophilia with elevated IgE level. Yeah, but like I said, in NSAID-induced nephritis, eosinophilia is not seen due to the inhibitory effect of the NSAID. Patients with allergic interstitial nephritis caused by NSAID may present with nephrotic syndrome with massive proteinuria, as we see in this patient, with protein of tubulosis, hyperalbuminuria with edema, as we see in this patient. In chronic TIN, patients are usually asymptomatic. The condition is often discovered incidentally on routine laboratory screening or evaluation of hypertension. Other general symptoms that occur with variable frequency include nausea, vomiting, fatigue, lack of appetite, and weight loss. And then subsequently, patient may present with features in keeping with end-stage renal disease. The patient may have flank pain, dysuria, hematuria. They may have hypertension, and it could be the most the most important pointer to the etiology. The classic triad of symptoms reported in early documented cases consists of rash, fever, and eosinophils. Increase in eosinophils occur in very small minority of patients. With modern drug causing between 70 to 90% of current cases, the possibility of a change in presentation exists. So how do we investigate this patient? Like I mentioned before, there could be eosinophilia, isocynuria, blood in the urine, sterile pyuria, nephrotic range protein will be seen. Where there is some condition, there will be low-grade protein. White blood cell cast may also be seen. So we can do full blood count where we see eosinophilia, but it's not specific because there are so many causes of eosinophilia. So because most of these investigations, the findings are not specific for tubular interstitial nephritis, the definitive diagnosis is renal biopsy, as we are going to see shortly. Electrolyte urea and creatinine will be elevated. Patient will present with metabolic acidosis. Abdominal ultrasound scan, non-contrast CT scan, KUB are all radiological investigation that we can do. We may see a normal kidney in acute TIN, while the chronic will give us a shrunken kidney, but then it can occur, a chronic TIN can happen with a normal sized kidney. Yes, but then whenever we see a shrunken kidney with increased echogenicity, it indicates chronicity, most likely with irreversible damage to the kidneys. Hydronephrosis is seen in obstructive diseases where stones are implicated. So both radiolucent and opaque stone can be picked by all of these modalities of radiography. So renal biopsy, which is the percutaneous biopsy with histopathological view, is the only definitive diagnosis and is the gold standard, where we see diffuse or focal inflammatory cells like the lymphocyte, plasma cell neutrophils, eosinophils, histiocyte infiltration, edema with fibrosis along with tubitis. In acute state, infiltration by mononuclear cell is seen, while in chronic states, there is fibrosis, tubular atrophy, which can be patchy, with heavy infiltration by inflammatory cell with vascular sclerosis. Dominant neutrophils and plasma cells suggest bacterial origin. Eosinophil may be present or absent, but not diagnosed. Like I said, it's not seen in NSAID-induced stain. Epithelial granuloma is rarely seen in penicillin-induced stain. So recently, there are non-invasive novel biomarkers which have been identified, including the NGAL, the chemokine CLL2, and then most recently, the interleukin-9 and tumor necrotic factor. They were all detected in higher percentage in patients with acute interstitial nephritis. So management, how do we manage the patient? Basically, like I said, is supportive and is directed to the cause. You see, the inciting agent, it should be withdrawn. Like in this case, the patient should be stopped from using NSAID. But most importantly, something triggered the use of NSAID. We must find out. Like in this patient now, since our highest index of suspicion is lupus nephritis, we evaluate the patient along that line. But then there are other causes of joint pain, which should also be evaluated. So other causes should also be evaluated, like the ANCA positive vasculitis, neoplasia, but then depending on the patient age. The patient is young, so we should look at the causes that is commoner in her age. Most patients that present with renal insufficiency should be managed by nephrologists. And this patient should be kept inpatient until they are stable. Hypertensive patients should be on low sodium diet. And for patients with early renal, DASH diet will be important. Hypertension should be controlled with ARBs. So like I said, all these drugs should be used, and subsequently in end-stage renal disease, they will benefit from renal replacement therapy. In most cases of acute tubular interstitial nephritis, so prognosis, the function of the kidneys will return to normal after harmful drug is discontinued or when the underlying disease is cured by treatment. If the illness is caused by allergic reaction, a steroid may speed the recovery of the kidney function. However, this is often not the case. NSAID generally carries worse prognosis. Chronic tubular interstitial nephritis has no cure, so it should be managed as end-stage renal disease. Some patients may benefit from dialysis and renal replacement. So in conclusion, tubular interstitial nephritis is a common cause of AKI and can be progressed to end-stage renal disease if the insult is persistent. Early recognition with prompt withdrawal of insult and management of etiology is crucial. Chronic tubular interstitial nephritis may progress to end-stage. I should be managed as such. Thank you.
Thank you, Dr. Obedia, for a lucid presentation. Thank you so much. So the class is open for contributions, and questions, comments are welcome. So you can type or you can raise your hand electronically. Any questions, any contributions? Okay, sir. Sir, the floor is yours, sir.
Good morning. Good morning, presenter.
Good morning.
Well done. I like the way you talk. With a lot of confidence, and you were almost very seamless in your discussion. However, I need to take you back to the question. Can you go back to the first slide that has the question on it? Okay, lovely. Now, this is a 35-year-old woman that presented with 3 pluses of protein in her urine. Okay? And then they showed the urea result, creatinine result, both of which are deranged. And then they said she's not a known patient with DM or systemic hypertension. And she has a history of NSAID use for recurrent joint pain for 4 months. And she also has pedal edema. Now, from this information given, I disagree with your diagnosis. In that if a patient has 3 pluses of protein in their urine, what that means is that the person is spilling at least 2 grams of protein in 24 hours. That's the implication of 3 pluses of protein in their urine. Now, there is no interstitial or tubular-interstitial disease that will make you spill that much protein. In other words, this patient may have some form of glomerular disease. That's the first thing, okay? Now, the other thing that they are giving us information here is that she has some kidney insufficiency, which is pointed out by the urea and the creatinine. Now, there isn't enough information here to mention that she has a tubular-interstitial disease. They also told you that her ultrasound scan is normal, meaning her kidneys are not too small and her kidneys are not too big, and coronary differentiation is preserved. That is what a normal ultrasound will point out for us. Okay? Now, in that guide, we don't have enough information here to say that the patient has nephrotic syndrome, but nephrotic syndrome is a specific entity. Now, it should also be noted that nephrotic syndrome is not a diagnosis. It is a manifestation of glomerular disease, meaning that if a person has a glomerular disease, it could manifest as nephrotic syndrome, and as well as many other things, okay? In this case, it could be a glomerular disease manifesting as persistent proteinuria, because as you can see, there's pedal edema, but there isn't enough to say that there was an attack here. Now, when you point out that, okay, and they now said, give us 3 differentials. Your differentials have to hone around glomerular disease. Now, yes, they've given us some information here. The recurrent joint pain, yes, you can start thinking it's some form of connective tissue disease, such as SLE or otherwise. Okay, because that would also give you glomerular disease and would be responsible for the 3 pluses of protein. Okay, now also she's been on NSAIDs. Yes, NSAIDs are known to cause tubular interstitial disease, yes, which will eventually lead to papillary necrosis and all of that. But you should also note that NSAIDs can also cause a secondary glomerular disease. In other words, it can cause glomerular disease that is not primary, but rather secondary in nature. Okay, so that is another possibility here. Okay.
Yes, sir.
Also, it's possible because of the age group of the patient. You can also start thinking of infectious diseases that can cause glomerular disease, of which it would also include HIV infection. Okay. Now, those are the things that we would point towards. It's going to be hard to prove tubular interstitial disease in this patient. And honestly, that's the truth, because you don't have enough information to point in that direction. If they had seen white blood cell cast in her urine, then you could say, yes, you start thinking of that as well. Okay, so your investigations and all of that have to point in that direction. I hope I'm making some sense.
Yes, sir.
Yeah, so in this patient now, how you want to investigate it, they've given you some information, you want to know a bit more. They didn't give you the electrolytes, so you need to know the electrolytes. They did not give you how much protein the person was actually spilling. They did just a urinalysis. Okay, so you may need to quantify how much protein she's spilling. Is that protein enough to be say it's in a nephrotic range? Okay, so you need to actually quantify it. So either you do 24-hour urine collection for protein, or you do protein or albumin creatinine ratio that will give you some idea of that. Then you may also want to look at the person's serum albumin, and all that will point towards the presence of a nephrotic syndrome or a glomerular disease manifesting as nephrotic syndrome. Okay?
Yes, sir.
For anybody that is spilling this much protein and you can't find any other reason, then you may also have to do a biopsy for the patient, and that will basically determine your management. Okay? So we're also thinking SLE, so your anti-double-stranded DNA, okay, and your ANA as well would also be important in this patient. Okay. All
Yes,
your
sir.
investigations will be tailored in and around all of this. There will be no need to do the ultrasound again. There's no point. They've told you it's normal. So you're not going to waste the patient's money. Okay. Then you may also have to check for other manifestations of SLE. So a full blood count may be required. Then of course, check for other autoimmune disease entities that come together with SLE. They also check for antiphospholipid syndrome and all of that. So I would rather you go in that direction with this particular question rather than going towards tubular interstitial nephritis. That's just my contribution. I don't know if Dr. Chief Remigos is in the house to lend me his thoughts as well.
Yes, I'm here. Chief, on class here.
Sir,
Yeah,
hello,
I think
sir.
you're
I have a
breaking.
little comment, sir.
Go ahead.
Okay, well, sir, well, when I saw the question initially, especially at the end when they asked about heart, I started thinking of Hivan, but then looking at the fact that Hivan patients present dry, they don't have edema. So I decided to downplay Hivan, but then is something that I should have thought of. Yes, but then
in this patient, I won't think Hivan first, because we know that Hivan is not the commonest manifestation of HIV, of renal manifestation of HIV current. It's rather the immune complex disease. And immune complex disease can present like this with edema and everything. So yes, Hivan is usually dry, I agree with you. But it's not the commonest anymore because basically everybody's on heart these days. So you don't see much Hivan. So we see more of immune complex disease. At least coming from South Africa, that's it. The gist is from South Africa. That's what they are seeing now. They're seeing more of Hivic than Hivan.
Yes, sir.
Yeah.
Yes,
Go ahead. I don't know to point out that.
I also thought about SLE, sir, but looking at the histology, the SLE which is present in affect the kidney like a lupus nephritis, the histologic finding is not suggestive of what we have because in the question they've given us a histological picture which is not suggestive of.
Oh, they gave us histology?
Yes.
Okay, where is I didn't see that.
Okay, the picture of light
picture. Okay,
of
showing
light microscopy.
Yes, showing tubular interstitial sclerosis, scarring,
atrophy,
yes,
and marked cystic dilation. Well,
yes.
I actually thought of the lupus nephritis.
Yes, lupus nephritis can cause this as well. Yeah.
Yes, especially the sclerosing type. Yes, but then I don't have enough history. The only thing I have is the joint pain. So
I think with the histology they're putting forward, we do know that anybody that is spilling this much protein, the end result of spilling protein is tubular damage. That's the truth. Okay.
Yes.
Yes, the problem is coming from the glomerulus. Yes, the glomerulus is already damaged. That's why you're spilling protein. But that protein is eventually absorbed by tubular cells and basically destroys tubular cells, changes them into myofibroblasts. They start laying fibrous matrix, and then of course you have your tubular interstitial nephritis. So if it's a late presentation of the patient when they did the histology, then it can point out this. But I think it's a very unfair histology to give you after giving you this particular type of clinical presentation. But nevertheless, I think you should try and marry the two together. Because sticking out your neck for tubular interstitial nephritis is difficult based on that history. That's the honest truth. But yes, with the histological findings and the presence of tubular scarring and all of that, you may point more towards a tubular disease. But I don't think it's tubular disease. I think they're just trying to throw people off course with this. And if it were Hivic, that's the immune complex disease in patients with HIV, it can actually present like this at the later stages. Okay. And
Yes.
of course, telling us that the ultrasound is normal, okay, may point towards that as well, because if the fibrosis has not become really bad, the kidney would not shrink. And that tells you that the tubules are not the primary targets as per the etiology. But if that was the case, then the chronic tubular interstitial nephritis will cause the kidney to shrink. So it tells you that it is still being damaged. The damage is ongoing.
Yes,
but it's
sir.
not yet reached a point where you can see it on ultrasound. I don't know, but it's not a fair histology to give after giving that history, or there could be something wrong with the recall. But I just think that it's difficult to play tubular interstitial nephritis, this presentation.
Hello?
Okay, sir.
Sorry. Would lupus nephritis be the final diagnosis or nephrotic syndrome from lupus nephritis?
What? No, you can't even say nephrotic syndrome. We don't have the gist to say nephrotic syndrome. We do know that there's a glomerular disease and it could be lupus nephritis. Okay, but you don't have enough gist to call it lupus nephritis because you don't have your immune complex, whatever. It could only suggest it, but you cannot, unless you have the your immune workup, then you can't make a diagnosis per se. The only thing we can say here is that the person is having some form of glomerular disease. Okay, and there are possibilities to the diagnosis. You can't say one thing. And if you notice, they didn't really ask you what the final. Okay, they asked you the final diagnosis. Okay.
Yes, sir.
Okay. If I'm going to stick my neck out for any final diagnosis here, well, I would stick out for SLE. I would say lupus nephritis.
Chief, sir, Fatima wants to give us clarification.
Okay, yes, Dr. Fatima, please. You went for the exam.
Yeah, good morning, Chief Shitu, Chief Christabel, Chief Remigos, Chief Bansi, and all our teachers present. Thank you very much, Dr. Gudia, for an excellent presentation. So actually, this question was a bonus in our exams because it was a recall. In fact, I was lucky to be the person that attempted it during our classes last year. The actual diagnosis is Hivan. I'm not too sure if this pedal edema is there or not, but Hivan, in fact, when I mentioned that when I saw the question, I was like, I started feeling happy, thinking it's likely the question that I knew. So I didn't go straight to Hivan. But they were asking me to rearrange my differential. So I brought Hivan first and I saw them writing it. So they were happy and the final diagnosis was actually Hivan. And I answered it all along the way we discussed it the other time. So it is actually Hivan. Thank you very much.
That makes better sense than tubular interstitial. Yeah. Hivan would be a close possibility here. Dr. Remigos, I thought you wanted to dive on this. I didn't hear your voice again.
To talk. But I don't know, it's as if you guys couldn't hear me. Can you hear me now?
Okay. Yeah, we can hear you now.
Very good. So, yeah, my thought is that Chief Shitu, your guy did not help them, and that's why people are scared of nephrology. This question was not a very fair question, okay? Because they didn't really, paint a clear picture of one particular thing. The only thing that was clear is that there was a glomerular disease. That is one very, and interstitial nephritis is more likely to have hematuria, proteinuria at times, most often times, okay, or leukocyturia and all that, than large quantity of protein in the urine for interstitial disease or tubular interstitial. But I wanted to present that to understand almost all these other glomerular diseases have an interstitial disease component, especially because of the large quantity of protein that they spill. Pneumonia is one of the most important risk factors for interstitial fibrosis and tubular fibrosis. And that's why nephrologists get scared of pneumonia. Know what it can cause. I would need to reduce the protein leakage. is tuberculosis. So now that picture, the final picture that was presented to me, any glomerular disease can lead to it finally. Hivan, lupus nephritis, they can lead to so the biopsy did not report other things. That's just like glomerular, finding the glomerular. It was just more tubular and findings that the histology showed. She saw that question on HIV. It should have triggered her to, yes, even Hivan can paint that histological picture. Okay? Most of Hivan get dry. And that's why the question more difficult. But saying that there was no pedal edema, it will have made one to look towards all those things. But because of the age, yes, and our environment, think of infections, parasitic ones, and all the rest, and HIV too, and viral infections. Okay, so very quick question. And is the candidates had a right to go towards tubular interstitial disease, so especially because of the histology finding and that the fact can cause tubular interstitial disease. But cause this glomerular disease too, especially minimal. So, at the end of it, finding if we would have modified, we would have them to hide. So, you know, they said I have, because truly I would have my neck more for lupus nephritis based on the age, the effect of the individual. Lupus can give anything. Lupus can give you glomerular disease, tubular disease. Lupus can give you my thoughts. Thank you so much.
Thank you very much for your contribution. Thank you. I'll read some of the messages that was sent. Dr. Joseph was wondering if she got the diagnosis correct. He was thinking of Hivan, and then Dr. Fatima had shed more light on that and our teachers. Dr. Inamdi said, could you? Yes, ma'am.
Yes, a quick one. That's one. So
yes.
A quick one. Chief Remingus and then Dr. Fatima has come in with the important some of the important matters. I just want to point that time management is a time properly, and she seemed to have spent so much time on giving us expose on a thing than on the question itself. We usually encourage that you are more elaborate on, you discuss everything on that question. Like if you sit in an exam, it ask you differential management, go to town. Then when you're giving us an expose, you just say, as I've discussed, you know, that's what you usually encourage. For one of time, please, you can move over to the next presenter. Thank you so much, Dr. Atta. Thank you, Dr. Godia. It was a very wonderful presentation. Thank you so much. You showed you did your research. Thank you.
Yeah, thank you very much, ma'am. So the next presenter, please, can you start sharing your slides? Dr. Godia, unshare your slide.
Okay.
Good morning, Shibansi, Dr. Christabel, and all our teachers present. While I'm sharing my slide, I want to please apologize for not being responsible as at when due, and to prepare my slide and present. So some family issues and stress. Please pardon me. I don't know if it's showing now.
Yes, but yeah, it's showing. So probably put it at PowerPoint mode.
PowerPoint mode. Okay. Sorry. Please, how can I do that? Sorry. Okay.
Yeah, down there.
It's on PowerPoint now.
Yes.
Okay, thank you very much. So good morning, my teachers and colleagues and everyone. I'll be presenting question 10 of the October 2020 West Africa OSCE. The question reads: a 35-year-old woman who presented with weakness and malaise. She's hypertensive, but blood pressure is well controlled. A kidney biopsy was done. Results revealed membranous nephropathy with features of class 5 lupus nephritis. There was no pleural urinalysis. Other lab features were essentially normal. She is currently on immunosuppressive methotrexate and intravenous cyclophosphamide, which was changed to mycophenolate mofetil. First question, list other investigation you would want to do. What advice and counseling would you want to do in regards medications and conception? 2, as regards renal disease and outcome. Following question, she later became pregnant. What complications do you anticipate? How will you continue to monitor her? So for the first question, list other investigation you would like to do. Being that the patients, the clinical pictures portray systemic lupus erythematosus, I want to do a full serologic panel. So I want to do extractable nuclear antibody and the autoantibodies, which may review which would review positive anti-nuclear antibody, anti-double-dead DNA, anti-Smith, and other auto-antibodies, including the ones suggestive of anti-phospholipid syndrome like anti-cardiolipin, beta-2 glycoprotein 1. I would also want to do urine microscopy. If there are presence of calcium, this may indicate presence of active disease. I want to do protein quantification. I would do spot and 24-hour urine protein quantification and do a urinary protein creatinine ratio. I would do electrolytes and urine creatinine, then abdominal ultrasound scan to look at the kidney size and also look at other possible causes of renal disease in this patient using these ultrasounds. I would also want to look at markers of disease activities. I would do erythrocyte segmentation rate, C-reactive protein, complements including C3, C4, CH50, then the anti-C1q antibodies, which is a disease marker for lupus nephritis. Systemic lupus erythematosus is SLE is a multi-systemic disease, so I would want to look at for other organ affectation and do baseline investigations. So I will do a full blood count. Full blood count, we may show pan cytopenia. I'll also do a liver function test, fasting serum lipid, nephrotic syndrome, which is one of the signs or features in lupus nephritis, is often associated with hyperlipidemia. So I want to have a baseline fasting serum lipid, a chest X-ray, ECG, echocardiography, cardiac disease, and where the patient may present with serositis is one of the features. I want to do chest X-ray, ECG, echocardiography, and also have a baseline with a viral screen. What will you do in terms of how will you counsel and advise the patient in terms of medication and conception? I would want to advise the patient that a multidisciplinary team, including the nephrology, rheumatologist, obstetrician, would team up to manage her as regard conception and even the primary disease. And I would counsel her that lupus nephritis in pregnancy can be successful when properly planned and managed with this multidisciplinary team. However, I will let her know that pregnancy in lupus nephritis in pregnancy is strongly associated with poor maternal and fetal outcomes, particularly when it's not properly planned. I will do a pre-pregnancy assessment and evaluation where I will take a history of previous pregnancies and outcome if she has had any. I would also look at do a clinical, take other history and clinical examination to look at clinical features that may be indicative of other organ involvements, and do laboratory and histologic, which the histology has already been done. So I'll do laboratory parameters to assess disease activity. Following this, I will stratify her into low or high risk patients based on these features mentioned. If she falls into the high risk group, for example, she has active lupus, the renal picture does not indicate that she has active lupus. She doesn't have proteinuria, no hematuria. Membranous nephropathy, which is class 5, is said to be associated with good prognosis compared to class 4 and class 6. However, other organs define being an high risk group. For example, if she has a serology that are suggestive of antiphospholipid syndrome or other severe organ disease like severe heart failure. So in this situation, I will counsel her against pregnancy and plan her on contraception. I would also give her options of assisted reproductive therapies like intravenous, IVF, in vitro fertilization and surrogacy, and also give her option of possible adoption if she so desires to have a child. If she falls into the low risk group, I would counsel her very well on fetal and maternal complications associated with pregnancy, in lupus nephritis in pregnancy, and I would educate her that she would have to be on she would have to be in an active disease state for at least 6 months, and this would be attained with proper medications and follow-up. And then I will discontinue her on any teratogenic medications. In this situation, she's on mycophenolate mofetil. I will discontinue that and place her on drugs that are safe in pregnancy in SL, like hydroxychloroquine, azathioprine, calcineurin inhibitor. If she has flesh, she would be on. Additionally, she would also have corticosteroid. If she's on ACE inhibitor or ARB for control of her high blood pressure, I will change her in view of the preconception. I will change her when she's pregnant. I will change the medications to drugs that are safe in pregnancy, like mitadopa, nifedipine, and labetalol. She would also be told to be on a low dose aspirin. She will be on regular maternal and a fetal surveillance by the multidisciplinary team throughout pregnancy, and also advise on the need to be adherent to medications. How will you advise her on renal disease and alcohol? For renal disease, as with pictures that is painted, she seems, as regards the renal disease, she seems to be in inactive disease state. However, I will counsel, and that means that she could have a renal disease remission, and advise her that she can have a renal disease remission, that have inactive disease if she's with good treatment and compliance with medications. However, I will also tell her that this condition, she could have a lupus nephritis flare, which will be indicated with clinical, laboratory, and histologic markers. She could also have progression to end-stage renal disease and may require renal replacement therapy like dialysis and renal transplantation, which I will educate her on about. Patient later became pregnant. What complication will you anticipate? Complications that may be anticipated in this patient could be maternal and fetal. For the maternal complications, there could be lupus nephritis flare with progression to end-stage renal disease requiring renal replacement therapy. She could have obstetric complications like uncontrolled hypertension, preeclampsia, Herpes syndrome, and even thromboembolic in bed like a CVA, and it could be miscarriages. Fetal complications will include a preterm delivery, miscarriages, intrauterine fetal growth, congenital heart block that is associated with neonatal lupus. How would you continue to monitor the patient? The monitoring the patients, like I said earlier, would be multidisciplinary, involving the rheumatology, nephrology, obstetrician, and she would be on regular and frequent maternal surveillance by this thing. During this period, she will have a baseline laboratory parameters, and would have serial laboratory checks, including full blood count urinalysis, electrolytes, creatinine, and urea, and protein fortifications. So that ends the presentation. This an algorithm I adopted from a journal, Kidney Medicine, summarizing preconception preparation in patients with assessing the approach to managing pregnancy, lupus nephritis in pregnancy. So it says that when the decision is made, it is a shared decision between the patient and the managing teams. And so the patient will be stratified into risk or low risk, and investigations, laboratory and histology investigations will be done, and assess disease activity and other organ involvement. Then if the patient has flare within this period of preconception, or thromboembolic events, or hematology parameters that shows anemia, pancytopenia, or features to suggest phospholipid syndrome, like recurrent miscarriages and previous births, the patient will be placed on gonadotropin releasing hormone. The pregnancy will be failed, and patients may be placed on the patient will be placed on gonadal releasing hormone analogs. Please, then may consider assisted reproductive therapy. Please, I'm sorry for the background noise.
Okay, try and round up.
Sorry.
Thank you. Okay, thank you for. I think you are done with your presentation.
Yes, sir. Yes, sir. Thank you very much.
So thank you so much for your wonderful presentation. So the class is open for contributions, comments, or questions. You can raise your hands electronically and unmute yourself to contribute.
Dr. Atta, there is a question. There's a question in the chat box, so you can read that.
Chat box, yes.
I'll wait for that.
Dr. Tanimu said, what is the lupus antibody associated with fetal heart block?
Okay, thank you very much for the question. So the antibody associated with fetal heart block is an anti-SSB and SSA and anti-RU-SSB. This is what is part of what will be done if we do a full serology panel, like that is extractable nuclear antigen and antibody. I said in the introductory statement.
Okay, thank you. Dr. Shitu, sir.
Oh, thank you. Sorry, I keep mixing up your name. I'm a class rep. Yeah, so well done to the speaker. Actually, the question is not a fair general medicine question. I'm sure there are even people in the subspecialty of nephrology that will struggle with this question. That's the truth. But the speaker spoke well and she put it together very well. I like the fact that you spoke generally to high risk, low risk. Now, note that when the patient is stage 5, membranous, okay, there is no going back. Those kidneys are still going to get to 6, become advancedly damaged and all of that, and the person is going to end up really bad. Okay, that's the truth. Once you get to that point, now most of the time, the people that we can salvage and turn things around for are people on stage 3 and stage 4. Okay, those are the ones that we can salvage. Those are the ones that have active disease, that the damage is ongoing. But in membranous, the damage is done. If you are just making a diagnosis at this stage, then you would want to advise the person not to get pregnant. Okay. Because we do know that pregnancy worsens the outcome in patients because it triggers off the process, it triggers off flares, and then of course worsens disease. Now you find out that 20% of patients with systemic lupus, their first manifestation may be lupus nephritis. Okay, and one of the triggers that tends to cause that lupus nephritis is getting pregnant. So many a times we do advise on if they have completed or they've had some success with reproduction and childbearing, we tell them, okay, this is time to take a step back from that. However, if they have not had children in the past and they're still willing to have children, it's not for you to take it away from them. Then advice on other options, as pointed out by the speaker, IVF, surrogacy, and things like that, so you don't, get the patient bad. Yes, it's important to give contraception to patients to have who are going to be put on immunosuppressives, particularly cyclophosphamide and MMF. Okay, you need to be careful with that. Now, for those that have disease that you can actually turn around, like stage 4, okay, if once they have gone into remission, you can start tailing them off these nephrotoxic agents, particularly the MMF and cyclophosphamide. Okay, but the person has to be in remission for at least 3 to 6 months before you think about pulling the stones. Then you take them off those things. They have to be off those drugs for at least 90 days. Okay, to be sure that the effect does not involve the child. Now, usually when they're on those drugs, we put them on contraception. So anybody that is on cyclophosphamide or is on MMF, okay, many a times we want to put them on contraception so they don't get pregnant while with it, particularly if there is kidney disease. And we know amenorrhea can occur in kidney disease, so their period may not be regular, and because it's not regular, they don't. They may not know when they do get pregnant. Okay, so we need to put them on some contraception. The choice of contraception may have to do with what the disease entity you're dealing with. Now, if the person has hypertension, fluid retention, you may not want to go hormonal. So you may want to use things like IUCDs. Okay, you can actually use hormonal IUCDs because hormonal IUCDs don't elaborate enough hormone to actually cause systemic issues. So you may go that route. Okay. Other things you can do, of course, are more permanent methods, and of course, barrier and things like that. Okay. Now, once you've been able to wean the patient off medication, once you're able to wean the patient off medication, then you can now consider a child bearing, but you have to monitor the kidney function over this period. Another thing you have to monitor, you have to be sure of before giving the person a chance to conceive is look at the renal function. Of course, if the person is end stage already, you may not want to take that chance. Or if the person is tending towards end stage, you're not trying to keep the person out of progressing to end stage, you may want to avoid that path. But if it's not so bad, if it's more earlier stages, then yes, you can give them the possibility. So there's no straight answer per se, but the speaker did very well and mentioned all the issues around it. It's something that's important for us to read. If since they are bringing it out as a question, I suspect it's something they can bring again, because I know a lot of people have had issues with it. That's just my contribution. But well done to the speaker. I believe you're a nephrologist.
Thank you very much, sir. No, I'm a dermatologist.
Dermatology, that's close enough. No wonder I didn't look at my SN.
Thank you, sir.
Thank you very much.
Doctor.
Yes, ma'am. Yes, ma'am.
Thank you. Yes, I just want to make a comment for once of time.
Thank you, Chief. Hello?
Yeah, you're welcome.
Very good. Chief, very good. Calm down. Wait first. So wait, please. So I want to commend the speaker. She did a wonderful job. Thank you so much. And thank you, Chief. Chitu has said everything. I wanted to say that the purpose of this class, like we always say, is speakers, participants, those going for exam, those in the source specialty where this question is being answered, should speak up. They should speak. I think Chief had to come in because you guys were waiting and we didn't want to waste time. So Chief had to come in. And Chief has said everything. Because Chief Chitu is quite good, he's a good teacher. So once he starts speaking, it will go around everywhere. So most time, once it's done, there's nothing to say again. So please, I want to encourage the participants, please. Speak up,
Oh,
speak
okay.
up. This class is for you.
Okay.
Please.
All right, you're welcome.
Thank you, sir.
You're
Dr.
welcome.
Kopi, Chief Remy Goose, let Dr. Kopi speak, then you speak, sir.
Oh, so sorry, please. I got typed it. I went for this exam and she did very well. In fact, well, the question took me by surprise. I did as much as I could remember, and they were ticking. When we came out, we heard a lot of things were surrounding what she did actually. But I was thinking if she could add some slides on lupus nephritis after answering the question and SLE, so it could more details to the others.
Dr. Becky, please just add the slides so that anyone going through your slide, you just need to revise. Chief Remy Goose, sir.
Yes, ma'am. Thank you.
Thank you, sis.
Thank you for the presentation. Sorry, sometimes I was just being logged off, and I just wanted to comment about the pregnancy one. Well, I'm telling you, for us here, if we just see somebody like that, I'll just tell them, please just forget our pregnancy for now, even though it's usually not the best approach. But the truth is, pregnancy in this kind of situation, just even SLE, even if it is quiescent, is very, very risky. Then if there's any derangement in renal function, especially someone that is in stage 3 CKD, we tell them to calm down about pregnancy, because pregnancy will just worsen the stage of the disease. The pregnancy is at risk, baby is at risk, mother is at risk. There are so many issues. So those are just the things I wanted to say about it. But of course, the diplomacy, all the other things, yeah, that's actually the route to go. You know, there are some people you cannot just tell them that they cannot get pregnant. They would hang themselves. Sorry, call came in. I hope you can still hear me. Can we still hear me?
Yeah, we
Yes,
can
sir.
hear you.
Sorry, call came in. So yes, there are some people that you can't just tell that they should forget about pregnancy because they really want it. So you have to go the diplomatic route, especially. But the best thing is to advise them on all those other alternatives instead of them getting pregnant themselves. But there's some people that will still insist. So if they are insisting, you can now go ahead to stress the points that yes, it's possible actually. However, we need the disease to be very quiescent. We need it to be in remission. We need all this before we can attempt it. We need your renal function to be as good as possible. All these things, because without them, the chances of you carrying the pregnancy successfully is almost zero, or is very low. Let's just put it that way. So we actually have a lot of these kind of cases. We see them a lot. Lupus nephritis. There's one patient that I have with sickle cell nephropathy. She's been wanting to conceive. Even the attempts before she came to me, all of them problems. She's already in I think stage 4 CKD by the time she came to me. And I've just told her, forget about this pregnancy for now. Your life is more important. So it's actually a very, very difficult situation. But I like the way you handled it. Thank you so much.
Thank you, sir, for your contribution. So I'll just read a few messages before we round off the class. Dr. Agbo said, I think, okay, Dr. Chukwu said, other complications include coronary artery disease and antiphospholipid syndrome. Agbo said, I think the examiners want us to consider surrogacy. Well, he said that's his thought. Dr. Chukwu also typed, is it important to inform the patient about the possible side effects of the drugs while counseling about medications? Yes, I think it's very important for you to explain to your patient. Very important. Then he said, what are your goals of management? Dr. Becky.
Thank you for the question. The goals of managing this patient is one, to counsel and educate these patients on this course, and to retard this progression, and to retard disease condition, and manage these patients in a multidisciplinary approach. Thank you.
Any other contributions or any clarifications?
We can round up. It's past 8.
So,
it's past 8.
Yeah. So we'll hand over to our teachers. So give their final comments.
Okay. Thank you. Thank you, Dr. Atta. Thank you so much for anchoring. Love your spirit and your attitude. The speakers today, Dr. Becky, Dr. Godia, Andrew, thank you so much. It was a wonderful presentation for 2 wonderful ladies. Thank you so much. And our participants, the questions, the comments, please keep it coming. The essence of this class is to make you to keep talking, keep speaking. The more you speak, the better you become. I believe one of the reasons why our active participants don't record this exam, don't repeat this exam, because of the fact that they keep talking. Once you're talking, no matter the question, you always find a way around it because you're talking. You also encourage to keep talking. So thank you so much for coming to class. Chief Bansi, sir. Chief Bansi. Please, Chief Chitu, Chief Ramigos, please close the class. I want to welcome our consultants, the fellows in the house. Thank you so much. I won't be able to mention the names because of the time. So thank you for coming to class. So I appreciate your presence. Chief Chitu, Chief Ramigos, please close the class.
Yeah, thank you, Dr. Christopher. So our time has already been overshot. Well spoken, the 2 speakers. See, throughout the matter, the first speaker, Dr. Godia, please don't be dismayed that you didn't get the diagnosis. I can guarantee you, with the way you spoke on that question, you will still pass it. Okay, sometimes getting the diagnosis is not all the math. In fact, it's maybe even the smallest part of the math. What they are interested in more, and I get that more and more every time I keep interacting with examiners, is that they are looking for your thought process. That is what they are marking. They want to see if